Okay, we're going to quickly do a demonstration on how to suction a patient in the intensive care unit. Two types of devices that you'll see are going to be something like this called a Yonker catheter, and it's going to be attached to a suction hose like this, and it's going to be plugged into behind the patient on the suction canister at the bedside. Most ICU nurses that have practiced a long time will have all this equipment set up even before they start their shift, because in an emergency situation this stuff has to be ready now, not when the emergency is happening. So let's pretend this patient's in the ICU. We'll pretend that he is being ventilated on the ventilator as such. There's going to be a tube holder here, or tape, depending on what the RT decides to do. And we've got lots of oral secretions. Studies have shown us that we use cast tubes at certain hospitals that suction oral secretions above the endotracheal tube. But a lot of research has been done. If good oral care is given in the ICU, it really does prevent, and the literature supports that it will prevent ventilator-assisted pneumonias. So it's very important for the nursing staff and the physical therapy staff, and anybody else that does oral care, to keep the oral cavity clean while the patients are in long-term ventilator care. And by giving good oral care, we'd like to suction out the secretions above the endotracheal tube. Remember, when the tube's placed, the cuff's inflated. So the person is normally so sick they wouldn't be able to swallow, and because of all these contraptions inside their throat, they're unable to swallow. So what we're going to do is you never place this device deeper than you can see with your eye. So if you're suctioning, you don't put this thing down any deeper than the back of the throat. And you're going to go inside. There's a hole to create the suction on all Yonkers. You could see this on the device, and when you have one in your hand, you'll see it. So if you push this in without covering up that hole, you're not going to get any suction. So what you're going to do at this point is go in and cover the hole and give suck out the oral secretions above the endotracheal tube cuff. So that's basically the oral cavity suctioning. We'll talk quickly about suctioning the endotracheal tube. So to do this, it's obviously very sterile. You don't want to introduce any type of bacteria or any types of foreign bodies down into the lung. It's a moist, warm environment, just ready to take over infection and bacteria. So we'll pretend the patient's well ventilated. We often will hyperventilate the patient or give 100% oxygen on the FiO2 with the ventilator, so they have lots of oxygen on board. I obviously have gloves on, and I'm protecting myself and the patient, and I have a sterile field set up. I'm going to go ahead and take out this catheter. Okay, it looks like this, big nasty tube, and you're going to measure from the patient's earlobe or nose to the earlobe to the zygoid process, which is about here, on patients, and that's typically where the carina. Actually, the carina is going to be up here, but you're going to only suction to about the carina. And when you meet resistance as you're going down the endotracheal tube, you don't force anything. You pull it straight back up. So let's say I measure my suction catheter correctly. I would get all this out of my way. There's often normal saline set up. I could suction, make sure that my suction's working correctly. I'm going to stick this in. I've been sterile. This is sterile because I'm wearing sterile gloves. I'm going to push this all the way down, and I've used my other hand to mark my mark where I need to stop. I'm going to push this all the way down until I meet resistance, or until I get to the part I gauged as to where I need to stop. If you hit the carina and the patient isn't paralyzed or heavily sedated, they will cough. That's a good indication that you're around the carina. At this point, you want to make circular motions and just slowly start suctioning at that point, all the way up to the top of the tube. And this often, at this size of tube, takes several passes. We do not recommend sticking any normal saline down the endotracheal tube. It's an old practice. And this would just happen, so you would make multiple passes until you cleared the lumen of that endotracheal tube. The struggle that patients have with these types of tubes, as I explained before, is they're very high risk of developing a pneumonia. And you know, when you develop a pneumonia, you have lots of sputum and lots of mucus. And often we get things called mucus plugs inside these endotracheal tubes. So if it blocks, then the patient is unable to ventilate, even with the ventilator. So it's very important that the nursing staff, the RT staff, or in some cases the physical therapy staff of, say, cystic fibrosis patients, really make sure they manage that suctioning of the patient correctly and effectively, it's really considered to be great preventative care.